Good evening, everybody. My name is Jenny Pearson. I'm one of the Education Officers for the Primary Health Network. Just before we start, I'd like to acknowledge the traditional custodians on the land that we all meet upon tonight and pay respect to elders past, present and emerging. Don't forget that you can use the chat box and Shan will be stopping during the presentation to answer questions. So please type in any questions that you have. We will be recording this webinar so that you will be able to access it on our People Bank site afterwards. Thanks very much, Sham.
Okay, good evening, everyone. Tonight we will be discussing about diabetes and pharmacotherapy. This is a part of diabetes masterclass part 1, which covers a lot of aspects, including screening for type 2 diabetes, pre-diabetes management, nutrition, type 2 diabetes, initial management, pharmacotherapy, renal failure, and many more things. But in this 1 hour session, I'm going to be able to talk only about the pharmacotherapy overall. Tonight, we will be covering a little bit about newly diagnosed type 2 diabetes and nutritional advice. What are the different types of dietary patterns and dietary advice we can consider? And what is after metformin these days? What do current guidelines discuss? Particularly the role of SJ82s and GLp1 analog and indications for insulin therapy in brief. I will touch upon diabetes medication and cardiovascular benefit as well as renal benefit. Now, before going into any further details, I would like to say that in Hunter, New England, more than 110 GP practices have been visited through Diabetes Alliance. And we recently measured our spillover effect into the whole practice data from the Alliance practices. And we have found some massive improvements in terms of process measures and outcome measures. So all of you have done extremely well. And we are open for business. We are visiting the GP practices back again. And we are looking for expression of interest at this stage, and we will be commencing our practice visits as usual next year, keeping social distancing and COVID restrictions in mind. Morag Joseph is our primary program manager now, so she will be able to give you more details. Now, coming back to tonight's program, I'd like to start by briefly mentioning about the diagnostic criteria for type 2 diabetes. If you remember the WHO definition, when somebody has cardinal symptoms of diabetes, such as thirst, polyuria, and weight loss, only one qualifying result is enough. For example, if somebody walks into your office and if he says, I'm thirsty and passing a lot of urine, you do a random glucose, which is 17 millimole, diagnosis is confirmed. You do not need to put them on a glucose tolerance test. However, if somebody has no symptoms of diabetes and you routinely tested them and fasting glucose is over 7 or equivalent to or over 7, then you would need an additional qualifying result. So in absence of symptoms, you need 2 qualifying results, preferably on 2 separate occasions. So as I said, fasting equivalent to or more than 7, and a random glucose or 2-hour post glucose tolerance test equal to or more than 11.1, or HbA1c of more than 6.5% or 48 millimole per mole, and any combination of 2 out of 3 in absence of symptoms would confirm the diagnosis. Now, if HbA1c sometimes can be elevated, for example, 6.7, but the fasting glucose may be under 6.9. That means it's a 2-hour value which is giving them the qualifying results, in which case you may have to go through glucose tolerance test. Otherwise, pretty much you do fasting glucose and HbA1c these days. You do not need to put patients through glucose tolerance test. It is inconvenient. They have to take time off and it causes a lot of problems. Now, I'm just going to give you some examples as we go through tonight, various topics. This was a case when I was on call last week. A 24-year-old male presented to GP Access with 2 months history of thirst and polyuria, 8 kg weight loss. His random glucose on that day was 26 millimole per liter. So obviously it confirmed the diagnosis of diabetes. I wouldn't say type 2 diabetes, diabetes confirmed. He was commenced on metformin therapy. What else should the clinician have done on that occasion? And are you happy with commencing metformin because glucose is 26 millimole? In other words, what are the risks of commencing metformin therapy or SGLT2 therapy in this gentleman? So just keep thinking about it. So while you're thinking about it, as soon as you diagnose somebody with type 2 diabetes or type 1 diabetes or diabetes of any form, please refer to health pathways, because health pathway tells you when to seek urgent assessment or advice. Whenever patient has persistent or severe hyperglycemia, even if it is one-off glucose of 24, you should consider asking for help. If the HbA1c is more than 11% at diagnosis, if the patient is particularly unwell or dehydrated, and presence of any ketonuria means they are insulin deficient and highly likely to be type 1, and therefore you should consider urgent specialist assessment. And of course, if you commence them on any medication and if they have recurrent hypoglycemia on medication, then perhaps urgent specialist assessment is needed. So the practice point here is, if somebody presents with glucose more than 17 millimole, you must always check blood or urine ketones. These days, blood ketones are preferable because it reduces the errors, and you should be able to check the capillary ketone level using Abbott Medicine's Optium meter. Very simple. Put the ketone strips like how you do the glucometer testing, and if the blood ketone is more than 0.6 millimole per liter, you need to consider sending them to ED. If it is more than 1.2 millimole per liter, you must send them to ED because they are going to need insulin initiation. So how do we, once you have diagnosed somebody with diabetes, the next question is, when do I worry about type 1? When do I think about type 2? Remember, type 1 diabetes usually presents in younger age, particularly children and adolescent and young people around 20-25. However, old age is not an exemption for type 1 diabetes. Even very old people, like in their 90s, can actually develop type 1 diabetes. What helps us to differentiate type 1 and type 2 diabetes is the symptoms: weight loss, polyuria, thirst, polydipsia, and ketonuria. Presence of ketonuria should be taken very seriously. And you may then proceed to check antibodies, which is usually GAD, IA2, or zinc transporter. There are 3 antibodies available now, and any of these antibodies positive means they have autoimmune diabetes or LADA or type 1 diabetes slow onset. So they should be commenced on insulin therapy because they can progress to ketoacidosis very rapidly. Remember, type 1 diabetes need external insulin injections for their survival. On the other hand, type 2 diabetes used to be in older age group who are overweight, and usually there is a very strong family history of type 2 diabetes or particular ethnicity, and they do not get significant ketonuria unless they have progressed quite a bit. And if you do test them for their antibodies, they are negative. They may present with DKA, but they're more likely to present with HONC or HHS, which is hyperosmolar hyperglycemic state. And of course, you treat them with lifestyle changes, initial oral hypoglycemic, and subsequently maybe they need insulin therapy, but you normally have time to build that up. But what is more common these days is, as I said before, type 1 diabetes affecting older patients, type 2 diabetes affecting younger patients, and a lot of secondary diabetes with mixed presentations, chronic pancreatitis, pancreatic surgery, certain types of medications, which make it quite difficult to give a clear-cut diagnosis. But if the glucose is more than 17 millimole per liter, and if they have any ketones, it is better to consider commencing them on insulin therapy, and subsequently we can work it out what to do in terms of orals, whether they're type 2 or type 1. So come back to our case. Our patient got sicker that night while he was waiting and commenced metformin therapy. He got admitted. I think his routine GP next morning sent him to emergency, thankfully. And his blood ketone was 5 millimole per liter. Remember, anything above 1.2 is serious, and anything above 3 is established ketoacidosis. His glucose on admission was 26, and he was acidotic. So he fulfilled the criteria for diabetic ketoacidosis. He got treated with intravenous insulin, IV fluids, and he was discharged home subsequently on subcutaneous insulin therapy. If you had commenced him on full dose metformin therapy, he could have developed lactic acidosis. And if you had commenced him on SJ82 inhibitor, certainly he would have got into severe diabetic ketoacidosis, and it may even have led to his death. So misdiagnosis has serious consequences. And I remember a general practitioner in the UK has been jailed for missing a diabetic ketoacidosis. And that is an extreme case. But in terms of good clinical practice, it is better for us to be safer rather than sorry. Now, I want you to think about this. Identify the following statements as true or false. Okay, each statement you have to come up whether it's true or false in your own mind. Type 1 diabetes occurs only in children. True or false? False, because it can occur at any age. Second statement, obese people are always insulin resistant and hence do not get type 1 diabetes. Again, this is false, because presence of obesity does not mean that they cannot get type 1 diabetes. They can get type 1 diabetes like slim people, but they just happen to be obese. So just because somebody is obese, you can't say they are type 2. Third one is insulin levels are diagnostic in diagnosing diabetes. True or false? Answer is false. Insulin levels may help you to guide type 1 versus type 2, but they are not diagnostic. Just because somebody's insulin is elevated doesn't mean that they've got diabetes. You have to have confirmatory glucose levels. Final statement, insulin deficiency and resistance can coexist, and this is true. Particularly, we see obese patients developing insulin resistance. Actually, they also have a lot of insulin deficiency. And again, to discuss that further, we will go back to face-to-face interactive 3-hour masterclass where we can teach you all these things. In the interest of time, I will confine to the prescribed syllabus today. Now, newly diagnosed type 2 diabetes, coming back to tonight's program, if the person is well and blood glucose is less than 17 millimole per liter, and typically if the HbA1c is under 9%, you initiate lifestyle changes such as giving up on highly refined carbohydrates, energy drinks, and initiate exercise, nutritional review, dietitian help, education as soon as it is possible and practical. However, you have to remember that 1 in 4 patients at diagnosis with type 2 diabetes have established complications. It is not uncommon for us to see retinopathy or renal failure or microalbuminuria or cardiovascular events in a newly diagnosed patients with type 2 diabetes. In fact, we pick up a lot of type 2 diabetes when they're admitted with coronary artery disease. Therefore, you must check their renal function, urine ACR, lipids, feet examination, and fundal examination as soon as it is practical. Within 3 months or within first 100 days, you should be able to commence these complication assessment. Then you arrange education with the diabetes educator and glucometers as appropriate. If it is a 70-80-year-old person, fasting glucose is 7 or 8, you may not need a glucose meter if the HbA1c is 7 or 8%. But on the other hand, if the fasting glucose is 15 millimole in a 40-year-old male with an HbA1c of 8.5%, it is better to give them a glucometer so that they understand the impact of food on their blood glucose levels. Then you call them back over 4 to 6 weeks time and review their blood glucose records and what they have been eating and whether you can influence them to eat better and whether the blood glucose levels are subsiding. And commence metformin therapy as soon as it is practical and acceptable, but do not delay commencing metformin therapy while you are waiting for lifestyle changes to be instituted. Caution here is when you commence metformin therapy, start 1 tablet with the evening meal and then slowly titrate over 4 weeks time to 2 grams a day, and rarely 3 grams, because as such between 2 grams and 3 grams there is hardly any glycemic or metabolic benefit. So our practice is to consider 2 grams of metformin, preferably slow release to minimize GI side effect. All this information is given on Health Pathway. You can look up. Now then, there are other subsets of diabetes. Sometimes it's not type 1, sometimes it's not type 2, and they have some underlying illness that predisposes them to develop diabetes. One must remain cautious about it. If the person presents with weight loss, unintentional weight loss, you must always think of type 1 diabetes. And the second most important thing you must be vigilant about is pancreatic cancer. In John Hunter, typically we pick up about 2 to 3 pancreatic cancer. Usually it is abrupt onset of diabetes, no precipitating dietary factors associated with weight loss. Typically age group is above 50 years of age. So consider pancreatic cancer, ask for specialist review, or consider triple phase pancreatic CT and pancreatic tumor markers. Occasionally we see neuroendocrine tumors in the pancreas as well, presenting with diabetes. If someone has rapid weight gain with diabetes, it is almost always due to excess of energy drinks, and of course they have to stop that. But then there are other conditions such as Cushing's can cause diabetes as well as weight gain. So just a brief examination about their muscle strength, proximal myopathy, abdominal striae, dorsocervical fat pad, any of those clues will alert you to Cushing's and they need specialist referral. Of course, if somebody has been on steroid therapy, they're going to gain weight and they're going to look Cushingoid and they're going to get diabetes as well. Any history of previous pancreatitis, pancreatic atrophy on the CT scan, or pancreatic surgery, that is called type 3C diabetes. They need to be referred to specialists because they are preferably treated with insulin therapy. Next one is lipodystrophy syndromes. This is an abnormal fat deposition, either a lot of central adiposity with no fat in the upper and lower limbs, or excess of fat in the disproportionate lower limbs or upper limbs. Again, these are very insulin resistant syndromes. They need appropriate management in terms of their weight, weight gain, weight distribution. It's actually quite difficult to treat these patients. You must also be alert to these checkpoint inhibitors widely used in oncology these days. A particular example is pembrolizumab. It can cause type 1 diabetes. We have had few cases like that, abrupt onset of diabetes, and without treatment, they will develop ketoacidosis. Any immunotherapy, people develop diabetes, always think about type 1 diabetes. MODY means maturity onset diabetes of the young. Often or typically there is a family history going back to 3 generations. There are about 14 subsets of MODY. There are a lot of genetic associations and other syndromic aspects in these conditions. In the interest of time, I wouldn't discuss that further, but it's good to be aware of that, and specialists can work it out whether they have MODY or not. And as I said before, slow type 1 or LADA, they look like type 2, but they may be in fact type 1 diabetes, and you check GAD, IA2, and zinc transporter antibodies. These are available on Medicare. Regardless of type of diabetes, you have to consider healthy eating, and we don't have to give patients very conflicting message. What we do is we use this Australia's healthy eating plate, which gives the very simple breakdown of carbohydrate, protein, fat, and vegetables, and 2 fruits. Then people come back and ask, oh, whether I should put my patients on ketogenic diet, paleo diet, vegetarian diet, intermittent fasting, very low energy diet, DASH diet, Mediterranean diet. All the information is very beautifully collated here from our dietitians, and the evidence behind it. the weight loss and benefits and risks and long-term evidence and adherence. Again, you can go through that at your own leisure, but the strongest evidence exists only for Mediterranean and DASH diet, and perhaps vegetarian diet to some extent because it's a plant-based diet, and very low energy diets can actually reverse diabetes, but it has to be done in an appropriate setting. So you can go through that. I wouldn't be able to go through that in detail because that alone will take about an hour to discuss. Next question is, when should we monitor glucose levels for patients with type 2 diabetes? Routinely, you don't need to monitor, but there are certain circumstances you should engage them to monitor their blood glucose, particularly anyone on insulin therapy, anyone who is at risk of hypoglycemia, such as those on SU therapy. When HbA1c is unreliable, for example, people with recurrent blood transfusion due to myelofibrosis and other conditions, or if they have a big spleen, or if they have iron deficiency anemia, all these things can make HbA1c unreliable. And there are certain types of hemoglobinopathies which actually again make HbA1c unreliable. There is a very good table on the health pathways. You can look up when HbA1c is unreliable, then you should be relying upon blood glucose monitoring to change their medications. And of course, certain types of occupation, such as miners and truck drivers, may have to satisfy blood glucose monitoring requirement. And if anyone is unwell or if they're symptomatic, you should monitor their blood glucose levels regularly. And once the HbA1c is rising, and when you're about to make decisions about commencing insulin therapy, and those decisions must be made on the basis of blood glucose monitoring and never alone on the basis of HbA1c. You cannot start, and you must not start anybody on insulin therapy just because the HbA1c is 11%, because you can cause terrible hypoglycemic episodes. So to understand the impact of food and exercise on blood glucose profile, again, monitoring for a couple of days, maybe 4 weeks, 6 weeks is beneficial. So NDSS will allow 6 months of strips. That should be sufficient. And if you want your patients to monitor more, then you give a letter of clinical need. Now coming to the pharmacotherapy aspect, what is after metformin? What is the contemporary evidence? So we have good old sulfonylureas, gliclazide, glimepiride, glibenclamide, and glipizide. In Australia, we widely use gliclazide MR or dimicron, and glimepiride is also used, but remember, this is a long-acting sulfonylurea, and it can cause prolonged and recurrent hypoglycemia, particularly in the context of renal failure. So do not use glimepiride if the GFR is below 45 ml per minute. Similarly, do not use glibenclamide on anybody because it's a very old-fashioned, severe hypoglycemia prone, weight gain prone, but quite an effective agent. But weight gain and hypoglycemia is a significant problem in glibenclamide. We have DPP4 inhibitor, which I will discuss in detail. We have GLp1 analog. Now currently we have 4 in Australia, 3 on PBS. We have in fact 3 SJ82 inhibitors on PBS. Many more are to come, and in fact canagliflozin is still available off PBS. Then we have all this insulin therapy, TZD, pioglitazone, and acarbose. If you want a bit more information, look at health pathways diabetes medication. Here I have summarized everything in the table. Metformin does not cause hypoglycemia. Typically, you get 1% to 1.5% HbA1c reduction. Limitation is particularly you should not be using metformin when the GFR is below 20 or 24 because of the risk of lactic acidosis. So you are quite okay to use metformin when the GFR is up to 30. Between 30 and 60, 1.5 grams, even 2 grams of metformin therapy is quite acceptable. But below 30, I would leave it to the specialist decision, particularly nephrologist decision, whether they want to continue metformin or not. If anybody has significant liver failure, cirrhosis of liver, not just abnormal liver function. Abnormal liver function is often due to fatty liver in type 2 diabetes. In fact, metformin is a good therapy for that. I'm talking about hypoalbuminemic ascites patient with established cirrhosis with the coagulopathy, you must not use metformin due to risk of lactic acidosis. The good thing about metformin is it is dead cheap, it's weight friendly, and it does keep the HbA1c under target for a long time, and we know that it is quite safe and it has got some CV benefit. Anyone on metformin, you should check B12 levels at least annually or once every 2 years, because metformin can reduce the serum B12 levels due to decreased absorption of B12 in the ileum, and therefore they are likely to require B12 supplementation. Sulfonylureas like diamicron, similar HbA1c reduction, but the hypoglycemia makes it harder to use, or the risk of hypoglycemia, and particularly the weight gain. But it's okay to use for a couple of years. It is quite a cheap drug, but you have to educate patients about hypoglycemia and monitoring. CV safety has been debated, but recent trial with the glimepiride has shown that there is no increased cardiovascular risks with glimepiride, and therefore I think that concern has not a problem anymore. We don't use glitazones these days because first of all, they are weaker agents. Second thing is they do cause edema, particularly macular edema and weight gain and CCF and small bone fractures. Therefore, it is fallen out of fashion. Acarbose is a good drug, but very weak in terms of HbA1c reduction. Its use has been limited due to GI side effect, but it has got good CV safety. Gliptins, again, similar to HbA1c reduction to SUs, but they have some warning towards pancreatitis. If somebody has had pancreatitis, do not use them. And they are weight friendly, they do not cause hypoglycemia, but they cost about $65 a month. SJ82 inhibitors we will discuss in detail. Now, this is the incretin-based therapy, particularly for gliptins and GLP-1s. As soon as you ingest food, what happens, your gut will secrete a hormone called glucagon like peptide 1 and glucagon inhibitory peptide, otherwise called as GIP. So what happens is in type 2 diabetes, this is rapidly broken down by an enzyme called DPP4, and therefore it is not very effective. So what it is meant to do, GLP-1 hormone, is to tell the pancreas to produce more glucose and also tell the brain to switch off appetite center. So as a net result, people eat less, the stomach slows down emptying, and because insulin is released from the beta cells and the glucose comes down, and as soon as the glucose comes down, insulin gets switched off from the pancreas. So by blocking this enzyme, this is called DPP4 inhibitor, you allow native GLP-1 to prolong its action. So DPP4 inhibitors or gliptins basically use body's own GLP-1 and they exhibit these effects. Whereas GLP-1 analog replaces this bit of GLP and directly kind of bypass and tell the pancreas to do all those things. So we have 4 DPP4. These are the DPP4s available, and this is the reduction in the dosage required in renal failure. Except linagliptin, you can continue 5 milligrams throughout. In terms of CV safety, 2 trials have shown that saxagliptin and alogliptin increase the hospitalization for heart failure, and therefore anyone with a heart failure, do not use saxagliptin and alogliptin. Stick with one, learn what's the dosage and what you should be adjusting in renal failure, and keep it simple rather than trying to keep up with all of these. The important thing here you need to remember is do not combine DPP4 inhibitor with GLP-1 analog. You're simply wasting money because they do belong to same class. And I see this all the time, Janumet and Byetta being prescribed together. Now, in terms of GLP-1 analog, we have quite a few in the market now. Byetta is exenatide, Trulicity is dulaglutide, semaglutide is Ozempic trade name, and Victoza or liraglutide is not yet on the PBS. I don't think it will come on the PBS because we have now long-acting GLP-1s. Now, average weight loss on these agents is about 3 to 5 kg, and HbA1c is about 1.5%. And they are injectable, and I'll set out the differences in the next few slides. Unfortunately, they do cause nausea, vomiting, or diarrhea, and we have to kind of explain that to patients very well, and that 4 to 6 weeks is crucial, and you may choose the one which is less likely to cause nausea and vomiting, and titrate the doses further. So weekly GLP-1s at this stage are not co-listed for insulin therapy, but we are hoping that it will come on the market for PBS very soon. I know a lot of our colleagues have been using that, and even I sometimes use it because I have to help out patients, but PBS unfortunately has not caught up with the evidence what we have. So this is the overview of GLP-1 receptor agonist. We have our native GLP-1, which is once a day is liraglutide, then we have dulaglutide and semaglutide, whereas the synthetic version is based on exendin backbone. We have exenatide and weekly versus twice daily. We don't have lexisenatide in Australia. It may come next year. But the difference here is the human GLP-1 backbone GLP-1s have better efficacy because they do not produce antibodies in the body, whereas exenatide 4 backbone body produces antibodies. So after 3-4 years, you might find the effect wearing off. Now, currently available GLP-1s, Byetta is twice daily. You start 5 micrograms, then you go up to 10 micrograms. HbA1c lowering typically on 5 micrograms is 1%, on 10 microgram 1.5%. It does help a bit of weight loss, maybe 3 kg. And in terms of renal failure, you can use Byetta up to 30, and below 30, I don't think you should use it. Unfortunately, CV trials did not show benefit, but they were non-inferior to placebo. There is an explanation behind that, but at the moment, I wouldn't say they have a strong CV benefit. Whereas Bydureon is weekly, 2 milligram dosage, a little bit more potent. You can use up to GFR 30. However, its use is limited because of cumbersome device and preparation time, and also some nodules you get, which are harmless basically, unlike insulin lipohypertrophy. But the device is not that good, therefore we tend to use less and less Bydureon at present. So that brings me down to Trulicity and Ozempic. Both are equally good, and they are weekly injections. The benefit of Trulicity is that it comes completely ready-made. All that the patients have to do is just take out the cap and twist it and inject it. And you will hear 2 clicks, it's done. You don't have to insert the needle, whole pen goes in the sharps bin. It is 1.5 milligram, single dose, good HbA1c lowering, significant weight loss, and you can use it in GFR up to 20 ml per minute. It has, in the Rewind trial, significant cardiovascular benefit in terms of atherosclerosis reduction, as well as renal endpoints in terms of doubling serum creatinine, GFR drop, and albuminuria. And same is true with semaglutide or Ozempic. It's also weekly, but here you have 3 different dosage, which I think is a benefit actually, 0.25, 0.5, and 1 milligram. If you start you should start 0.25 and titrate it monthly or 2 monthly to the next dose. And there is some evidence that when you start 0.25 versus 1.5 milligrams of Trulicity, the side effects are a lot less in 0.25 because body gets used to that. Then you do a slow titration. Unfortunately, Trulicity did not bring their 0.75 milligram dosage to Australia, and they have only 1 dosage here. And the other thing you need to know is that 0.5 of Ozempic is equivalent to 1.5 of Trulicity. So for added weight loss and HbA1c lowering, you got to push patients to 1 milligram dosage if they can't tolerate. Sometimes you get anywhere between 6 to 10 kg weight loss. That's actually very impressive. And again, you can use them up to GFR 20. I would say very strong CV benefit and renal benefit. in Ozempic. But remember, all of these GLP-1s have a warning towards worsening retinopathy. That means if they had background retinopathy, if their HbA1c is more than 9% at commencement, you may actually transiently worsen their retinopathy, which will settle down later, but you need to be vigilant into that. If HbA1c is 10, 11, 12%, have a baseline retinal screening done and have 6 months another screening done so that you are picking up any retinopathy that is worsening. If there is any evidence of maculopathy or macular edema, that needs to be treated. Now, how to minimize the side effects of GLP-1 analog? You must warn your patients to have small meals. And if they are not hungry, do not forcefully eat. The whole purpose is to decrease their appetite anyway. They have to increase fluids, not with the meal, in between the meals. And if they had any acid reflux, use antacids, but preferably not PPI, because PPIs delay the gastric emptying and that can cause further problems. And avoid GLP-1 analog in anyone with gastroparesis. And you must tell them to avoid fatty meals because that also decreases the stomach emptying, which can cause more side effect. Now then the question comes to people's mind, should I choose a gliptin? Should I go for Januvia or should I go for Trulicity? I've set out the differences here. This is a weaker agent, gliptin. GLP-1 is a stronger agent and it has added CV benefit and renal benefits. And therefore, as for only benefit of gliptin is it's oral, you don't have to inject it. But if you want to give them extra mileage for their heart and kidney, you need to start GLP-1 analog as soon as you can. After metformin, you can either choose SJ82 or GLP-1 analog, and I will explain that guideline in a minute. But do not combine these two agents. Now coming to SJ82 inhibitors, you need to understand the normal glucose metabolism. Typically, we have 250 grams of glucose uptake per day, and body produces about 70 grams through hepatic glucose breakdown, and dietary intake is about 180 grams typically, and brain uses half of it and rest of your body uses half of it. And in health, everything is in equilibrium, and kidney kind of reabsorbs 180 grams of glucose per day. So this is your kidney, this is the glomeruli, this is the afferent arteriole, this is the efferent arteriole. Remember, ACE inhibitor dilate this efferent arteriole and thereby reduce the intraglomerular pressure. So how what happens is when the glucose is filtered, there is something called proximal convoluted tubule. This is where the sodium and glucose gets reabsorbed, and that gives the feedback to these two arterioles, and then they adjust how much blood to be brought back again. And the excess glucose should go through this. In type 2 diabetes, what happens, too much glucose gets reabsorbed back in the proximal tubule. There is upregulation of the mitochondria and ATP. And in the long term, what happens is, because this is a very active process, the ATP's production gets exhausted, mitochondria gets exhausted, proximal tubule atrophies. That means they develop diabetic kidney disease. So what these SGLT2s do is basically they block this proximal tubule reabsorbing the glucose, and therefore it goes out in the urine. Because of that, there is a feedback here, and that also what it does is that it constricts the afferent arteriole and thereby decreasing the glomerular pressure. And therefore, typically you see about 5 ml drop in the GFR, but it protects the kidney in the long term. On average, you lose about 70 grams of glucose on SGLT2, which is typically 280 calories. That explains the weight loss. And this is the hypothesis that this may actually improve the survival of proximal tubule. But although they are good class of drugs, you must remember certain do's and don'ts with SGLT2. You must always ensure that the renal function is adequate, above 45 ml per minute. And if you are using it between 45 and 30 ml, you have to be cautious. And if it is below 30 ml, I do not recommend using this until further data is available. You also have to explain the risks of genitourinary infection. About 5 to 10% And although men are less likely to get it, they probably have no first-hand experience of thrush. They are unlikely to come and seek advice. So you got to literally explain what a thrush mean and what to do and when to come and seek advice. Most importantly, ask them to stop this drug during intercurrent illness because there is an increased risk of diabetic ketoacidosis. And again, before any surgery or procedures, this drug must be stopped for at least 3 days. And avoid SGLT2 inhibitor in anyone who is on low carb diet, previous DKAs, type 1 diabetes, or those who are unreliable in terms of follow-up and everything. So SGLT2 inhibitors and DKA, they cause DKA in about 1% of patients. Although it looks like a small number, we have about 70 to 80,000 patients in Hunter, New England. 1% is a lot of DKAs that we get. Diagnosis is often delayed due to lack of awareness among the clinicians. Patients present really non-specifically, and blood glucose level may not be significantly elevated because of the glycosuria, typically less than 14 millimole per liter. And that means they are not likely to have a blood gas done. They're not likely to have pH measured. They're not likely to have urine or blood ketones done. So they get sick and sick. Word of caution is that urine ketones may be misleadingly low. So therefore, anyone on SGLT2 inhibitor, we prefer capillary ketones. And as I said before, above 0.6 caution and above 1.2 must be directly sent into emergency department. And they are likely to require insulin and dextrose infusion to recover. Now, factors predisposing to DKA with the SGLT2 inhibitor. Most common precipitant is any anesthetic surgery that causes stress and they have DKA. Any acute illness, insulin dose reduction. If somebody is on insulin, you are commencing SGLT2, do not stop insulin because they may be truly dependent on insulin therapy. Anyone on low carbohydrate diet, which is defined as less than 50 to 60 grams per day, malnourishment, heavy alcohol use, those who are predisposed to severe dehydration, and insulin deficiency from any cause such as pump failure, history of pancreatitis, or pancreatic surgery. So you must not use SGLT2 inhibitor. Certainly at this stage, do not use it on type 1 diabetes because we have had life-threatening diabetic ketoacidosis. If you want to use it in any of these group, then you must supply them blood ketone meter and ask them to monitor their blood ketones on a daily basis. And if they are reaching 0.6 millimole per liter, they must stop their SGLT2 inhibitors. So then the next question is, which SGLT2 inhibitor should I choose? I have got 4 currently, and that's Jardiance, empagliflozin, dapagliflozin, Foxegas, Tegaltro is R2, and Invokana is canagliflozin. And canagliflozin is not available on the market as PBS, but private script is still available. These are the different doses, and HbA1c lowering is not that spectacular. Interestingly, it's only 1%, but we use it for added benefit of heart and kidney health. And major cardiovascular outcome trials have shown decrease in 3-point MACE, that is heart attack, stroke, and heart failure, and CV death, as well as heart failure for Jardiance. Spectacular trial results from EMPA-REG. And this one is dapagliflozin did not give 3-point MACE reduction, but there was a decrease in the CV death and heart failure. That is because they went for primary prevention. That means these patients were a different group of patients, younger patients, haven't had heart attack before, whereas EMPA-REG study was after the heart attack or a very high risk of heart attack patients, and therefore they were able to show strong decrease in the event. Interestingly, L2-gliflozin did not show any statistically significant benefit. There was some trend towards heart failure reduction. So you cannot call it as a class effect now. You got to know the individual differences in these agents, empagliflozin versus dapagliflozin. And similarly, canagliflozin was more potent in terms of HbA1c lowering, and it had a very strong event reduction in terms of cardiovascular endpoints, death and heart failure. And also credence trial shown in patients with renal disease, it was able to prolong the renal function and decrease the requirement for dialysis. But unfortunately, it went out of PBS because of lack of price reduction negotiation with the government. And again, remember that all of them have to be discontinued at least 3 days, whereas ertugliflozin has a longer half-life, and therefore you would need to discontinue that at least 5 days before any surgery. Now, these are the class effects of SGLT2 on cardiorenal outcomes. And as I said, DECLARE TIMI had more primary prevention, 17,000 patients, predominantly GFR above 60, Canvas trial above 60, and John Hunter was a site. I was one of the lead investigators locally. EMPA-REG outcome trial, again, more patients had GFR more than 60, whereas in the credence trial, you have a lot more patients in eGFR under 60. So what it shows is different SGLT2 inhibitors and different event rate. When you look at DECLARE TIMI, there was a reduction in 3-point MACE, but it wasn't statistically significant due to the patient population. And heart failure was statistically significant. And this was heart failure and CV death, where this one is hospitalization for heart failure, quite an important reduction. CAN was much more robust in all domains, and EMPA-REG, you see that big difference in terms of 3-point MACE, and this one was heart failure or CV death, a massive difference, and again heart failure admission rates were significant. And this credence was done in patients with significantly reduced GFR. That means under 60. I'm not saying under 30. Those trials are still currently happening. We do not have evidence to say that it is effective. It is going to be showing that maybe in the future, but at this point, I can't advocate that. And it was quite a powerful reduction in terms of all the cardiac and renal endpoint. And this is the composite renal endpoint. When you look at the serum creatinine doubling or eGFR worsening or dialysis related death, you see that canagliflozin was very good in terms of event reduction in high-risk renal patients. But empagliflozin also is good as well as dapagliflozin. So at this point of time, ertugliflozin does not provide us that benefit. So you have to be careful in choosing which one you want to use. So I discussed almost all of them now. And similarly, GLP-1 receptor agonists also have CV and renal benefit. I haven't shown you the data. There is Rewind trial and Sustain trial from Trulicity and Ozempic. So you got to consider one of them, either SGLT2 or GLP, for heart and renal benefit. Now, this is your college guideline, and it is quite complicated to read through, but what they're saying is that metformin is first line, then you have the option of SU or insulin or SGLT2, DPP4, GLP-1s. Pretty much you can use anything, but what should alert you is these little signals. They will tell you the cost and basically the cardiac benefit and the renal benefit. And therefore, I would also show you the American and EASD guideline. Here, we have a different take. If somebody has had any cardiac event, any previous stent, any previous heart failure, any previous coronary artery bypass graft, or a high-risk patient, heavy smoker, peripheral vascular disease, and all those things, you must consider them for SGLT2 inhibitor second line. If you can't use SGLT2 inhibitor because their GFR is like 35 or 40, you choose GLP1 analog with the proven benefit that at this stage is Trulicity or Ozempic. On the other hand, if CKD predominates, for example, somebody has microalbuminuria and or they have GFR above 45 but below 60, and you would get a lot more mileage by commencing them on SGLT2 inhibitors, and that's your second choice. And if you're not, you can use GLP1 analog. So you got to consider those two. In a low risk patient, when they don't have any of these consideration, these drugs will still give that benefit. However, if you want to use other agent like DPP4 inhibitor, for instance, an 80-year-old with HbA1c of 7.8%, you don't want to give her the risk of UTI, you don't want her to lose weight or cause nausea, it is fair to give her DPP4 inhibitor. And TZDs, for example, have now almost become a reserved drug. And yes, you can use it if it is a cost a major consideration. You use SU and TZD. And I don't think in Australia it is a major concern. So we got to consider SGLT2 or GLP1. Now you can also ask me what happens if I use both together, SGLT2 and GLPs together. In real life, you would get extra benefit, but PBS hasn't allowed that to happen. It may happen in the near future. Now, coming to third line, you have commenced them on Metformin and SU. You're adding a third line agent. What is the extra benefit you are going to get in terms of HbA1c lowering? Here, you see that the efficacy of the third line agent against Metformin and SU, because the SU has already stimulated the pancreas to maximum extent, and Metformin has already looked at the liver in a significant in terms of hepatic glycogenolysis aspect. Then when you add, you probably will get a better deal with the SGLT2 because they bypass the pancreas. Of course, you still get the cardiorenal benefit, but I'm talking about the HbA1c lowering. Gliptins do not seem to do much, and glitazones do not seem to do much, whereas GLP-1s and insulins tend to give you the maximum benefit. In other words, if somebody is on, let us say, Metformin, SU, and a gliptin, you now have to think, what should I do? Well, you can give Metformin, SU, and a GLP-1, or if the HbA1c is 11, 12, 13%, you may have to do Metformin, basal insulin, SGLT2, or Metformin, basal insulin, and GLP-1. That's how you need to start thinking about. So despite better medications available, insulin therapy is still needed because type 2 diabetes appears to be progressive. And even with all these fantastic molecules, patients still have HbA1c of 11%, which is sad. Now that brings me down to indications for insulin therapy in type 2 diabetes, which will be covered in detail in part 2 of master classes. Hopefully I will see you face to face next year. And the indication is to prevent or treat DKA or HHS, and those who are presenting with the thirst, polyuria, or weight loss, anyone who is pre-pregnancy or contemplating pregnancy or during pregnancy, you cannot use any other medication. When the glucose crosses 5.5 or more than 7 postprandial, you need to start insulin therapy. Typically, steroid-induced hyperglycemia, if the glucose is more than 15, you got to consider insulin therapy. And those who are waiting their joints replaced, heart opened, all the major surgery due to risk of infection and DKA, we got to give them insulin before and keep their glucose between 5 to 10 and HbA1c under 7.5. You commence them on insulin therapy, even though temporarily, then you sort it out what you can do post-operatively. And of course, those who are LADAs, you got to give them insulin therapy. In the typical general practice setting, you would have trialed them on 3 agents and or GLP-1 and they're still failing, then you got to consider insulin therapy. Now, I'm just going to go through a couple of cases in the next 3 minutes, and then you might have a minute or two for the questions. This is a 76-year-old lady, type 2 diabetes for 10 years, hypertension, obesity, sleep apnea, normal renal function, no microalbuminuria, mild retinopathy, blood pressure is okay on ACE and statin, HbA1c is 8.4, and diet is reasonable. Which agent would you give and why? So you can give her SU, but you got to think about the risk of hypo. You can give her gliptin, it's quite reasonable. She's 78. You could give her SGLT2, but she may have had recurrent UTI. You got to ask that question. She's postmenopausal. I don't know whether she had vaginal atrophy, whether she had previous estrogen therapy. And she's obese, she's got sleep apnea. I would now go for GLP-1 analog as a second line therapy because I know I can get a bit of weight loss and that would help her sleep apnea. Next case is 54, ex-smoker, hypertensive, BMI is 35, pre-diabetes and type 2 diabetes. He had STEMI, treated with a stent. HbA1c at diagnosis 8%. He was commenced on Metformin, now on maximal Metformin. Latest HbA1c 7.5%. And you might say, oh, he's doing quite well, I'll sit tight and do nothing. That's not acceptable in 2020 when you have agents that would reduce 30 to 40% risk of death. Therefore, the answer here is very specific. Based on the clinical trial data, you would commence him on empagliflozin. If he had any DKA or severe urinary infection, then you ought to consider him for GLP-1 analog. Next one is 35-year-old, symptoms of tiredness, random glucose of 15, HbA1c 9.5. He's obese. Sorry, there's a lot of typos, ignore that. He gave up his Coke, lost 4 kg weight. On review 6 months, HbA1c 8% on maximal metformin therapy. What would be your second line? Would you give him SU? Would you give him a gliptin? Would you give him SGLT2? Would you give him a GLP-1? And here I would tend to use GLP-1 because he's obese, he's 35, and any weight loss would be significantly benefit. Then I'm hoping that SGLT2 will be co-listed to be used with GLP-1 in the future. And of course, if he doesn't want to inject, then you can go on to SGLT2 as the second line, and you must have a conversation with him about bariatric surgery and try and get the bariatric surgery as soon as you can. Then you can get him off diabetic medication. That might be the motivation. Next case is fasting blood glucose 10, HbA1c 8.5, BMI 24. He's 50 years old and he's very healthy. His son has type 1 diabetes. So here, I want you to think why he got diabetes. This is an atypical form. And his BMI is 24. He's got a good lifestyle. And you must think of type 1 diabetes, especially when his son has type 1 diabetes. So you do the GAD antibodies and other antibodies. If they're positive, you should consider early basal insulin therapy. You must avoid SGLT2s due to risk of DKA. Now, case 6 is last case. He's 60-year-old, 15 years of type 2, metformin and gliptin, HbA1c 7.8%, on all appropriate medication. GFR is 58, urine ACR is 15. Which additional class agent has shown significant reduction in renal endpoint? The answer here is SGLT2 followed by GLP-1 analog. So I will now stop and take any burning questions, although time is running out very quickly.
Hi, Sham. There's only one comment, and it was at the very beginning when you were talking, and it was a comment, and it simply says urine ketones.
Okay, urine ketone, as I said before, preferably we advocate blood ketone. If you don't have it, you do urine ketone. And if it is 1+, you may have to repeat the sample. If it is 3+, 4+, that means it's large ketonuria. You must consider early insulin initiation. They may already be in DKA. You need to send them to emergency department at diagnosis.
That's all the questions we have.
Okay. Back to Jenny then.
Thanks so much, Sam, and thanks, Morag. Thanks, everybody, for attending tonight. We're doing another 3 webinars with the Alliance in February. The next one will be Tuesday, the 9th of February. And that will be called Diets Explained. So keep an eye out for the registration details, and I'll send them through over the next few weeks. Thanks very much, everybody, for your time. Good night.
Thank you.